And I would now like to hand over to Kama and to introduce this session.
Thank you very much, Berit. Thank you very much, everybody. This is the world we live in. Technology sometimes can do this to us, but we become stronger when we overcome. So I believe that the next few minutes that are left, we're going to be able to overcome. Our meeting this morning is on a topic that should be very, very common in all health meetings, but is often not as common as it should be. Disability is not inability. It is something that we know exists. It's inevitable. And yet our preparation for it and our mitigation for it has always been in short supply. That's not just in Africa, but globally. For us in Africa, the focus that has been on making the best use of people who do not have any disability at all, and our failure to do so has made us completely miss the opportunity of harnessing the vast, vast potential that people with any form of disability have. And the mitigations are not always expensive, nor are they not unachievable. It's simply that we don't care enough. But luckily, there are people around the world who care enough. And this has led to a lot of innovation and new ideas and technology. Technology is making the world do things differently and run things differently. An example is just this very meeting that is bringing us together from many corners of the world to discuss this very topic. If we use the same kind of confidence in using technology to assist those who have any form of disability, then the world could be a richer place. And this is what we want to discuss this morning. We have a rich panel here of experience, and we thank you for being here for us. We also thank you for bearing with us on the shortcomings of technology. So I will ask you something that is already difficult because I'd already asked you to be fairly keep time and be short, but I'm going to ask you to be even more than that now so that we get everybody on and get the idea. You are all very well known people in your field and eloquent, and I'd like us to start right away by asking Berit to give the opening remarks. Berit. You're muted, Berit.
Thank you for giving me the opportunity for the opening. However, I would like to hand over to Alison, since she will be our first speaker and giving the frame and giving you a brief overview about the initiative 80 Scale and what they are doing to improve access to quality, affordable and appropriate assistive technology. I'm really looking forward to her speech. Thank you. And up to you, the floor is yours, Alison.
Thank you so much.
And if I may ask everybody, I will not spend time introducing you, so just remark a few things on yourself and proceed. Over to Alison, welcome.
Thank you so much, and good morning to everyone. I'm honored to be here. My name is Alison N. Feinberg, and I'm the Director of AT Scale, the Global Partnership for Assistive Technology, and I'm based in Geneva, Switzerland. I'm honored to be a part of such a distinguished panel representing exactly what is important for assistive technology, bringing together stakeholders such as civil society, the private sector, national governments, service providers, and users of assistive technology to discuss what's needed and decide what action we should be taking together to improve access to life-changing products and services that support people to live fulfilling and dignified lives. Excuse me. When we talk about assistive technology, or sometimes I may refer to it as AT, this is an umbrella term covering the services and the systems related to the delivery of assistive products and services. So if we think of wheelchairs, prosthesis, eyeglasses, hearing aids, and these assistive products are any product whose primary purpose is to maintain or improve an individual's functioning and independence and to facilitate participation. Today, over 1 billion people need at least one form of assistive technology, but over 90% do not have access to the AT they require. This means there are more than 900 million people who are currently living without the products and services they need. And the need and the gap in access is disproportionately high in low and middle income countries. It's estimated, for example, that at least 10 million people in Africa need a wheelchair, but only 5% have one, as compared to 90% coverage in high income countries. And we know also about 5 million people in Africa could benefit from a prosthesis, and the percent who have them is similarly low. And we also know that the numbers are growing globally. It's estimated that 2 billion people will need at least one form of assistive technology by 2050. Access to appropriate assistive technology enables people to participate more in education and work, in family and community life. And based on recent modeling, we understand that provision of 4 assistive products, so eyeglasses, wheelchairs, hearing aids, and prosthesis to all who need them today, would yield more than $10 trillion over 55 years, or a return on investment of 9 to 1. And it could also result in over 1 billion quality adjusted life years gained. We know that assistive technology can help unlock the potential of hundreds of millions of people and promote more equitable outcomes for all. And the impact is not only for the individuals, but for their families, communities, and entire nations. I mentioned that I'm the director of AT Scale, which is a global partnership that was launched to focus on increasing access to assistive technology, particularly for individuals in low and middle income countries. Given the extent of the need on one hand and the scarcity of resources on the other, as well as the potential for huge benefits, as I just mentioned, the approach to increasing assistive technology access needs to be strategic and coordinated. And to truly increase access, we'll need to focus both on developing an enabling ecosystem and on building and shaping markets. So from an enabling ecosystem perspective, this means addressing a wide range of systemic underlying environmental challenges and cross-cutting factors. We'll need to increase political will for prioritization of assistive technology. We need to mobilize significant resources. We need to ensure there's more robust data to help inform and drive investment. We need to reduce discrimination and stigma and increase awareness. And we need to address cross-cutting policies and systems. It will be particularly important to emphasize national strategic planning, costing, and policy work that can lead to robust, holistic in-country programs that are locally owned. And I believe we'll hear about some of those areas where there have been successes today as we move forward in the panel. As we look to the most strategic investments, we need to understand the barriers to invest strategically in the solutions that will help us overcome them, and also to continue to learn from these investments. So from a market shaping perspective, as we think about what's really needed, we know there are many supply and demand side market barriers. And as AT Scale, together in partnership with the AT 2030 program and driven by some of the partners here today, such as Chai, we were able to do an in-depth analysis for the 5 priority products that AT Scale is focusing on initially, to look at what the key gaps are and the barriers that we need to overcome. And these are translated into a document called the product narrative, which describes these key barriers and promising interventions that span from research and development all the way to service delivery at the user and healthcare worker levels. And these product narratives are a strong basis for initial action and investment plans, which we as AT Scale will invest in, and we also hope that we can bring other partners to invest in and to implement. And as we invest in these and we show results, these results combined with expert consultation will allow us to continue to refine our plans, and these can translate into longer-term sector-wide strategies for improving access to these products and related services. And throughout this, it'll be really critical to work with national governments and local organizations, many of whom may be here today, to develop solutions that are really appropriate for each setting. We'll need individual countries to be leaders in demonstrating what's possible. We'll want to collect that evidence, and then we need to commit to scaling up those solutions. Just very quickly, these product narratives that I've mentioned, they highlight some strategic objectives that can guide us in a way that helps us focus our resources and our efforts in a coordinated way in line with what's most needed. So for example, we know we need to build and stimulate demand through the integration of wheelchair services as an example, including procurement and provision into national healthcare systems. We're here today talking about health. These need to be a part of our health systems. In many cases in the past, countries have relied on donations of wheelchairs, which have sometimes not been the appropriate products or without the related services that are needed. And country governments have, in some cases, been disincentivized to procure them. We need to really change that and have holistic programs that address this. In the case of prosthesis, we're going to hear more about this a bit later. A primary strategic objective is to support countries to define appropriate policies and invest in the key requirements of a functioning prosthetic provisioning system. I've mentioned being coordinated, and as a global partnership, AT-Scale enables partners who work in distinct sectors to come together on unified strategies, and it facilitates complementary approaches, innovation, and capacity building. And bringing these different stakeholders together is crucial to enable us to set ambitious targets. We've set out to work with all of you to reach 500 million more people with life-changing assistive technology by 2030. But in order to do that, we're going to need a unified strategy. We're going to need to make sure that we're implementing the best solutions, taking into account the perspective, strengths, and expertise of all stakeholders. And we know that working to address some of the huge gaps is too big for any one organization or group of people to deliver. We're so fortunate to be part of this Regional World Health Summit, and we need to be sure we continue to ensure that assistive technology is a core component of health discussions, of global health and development goals. And following me, you'll hear from many of these different stakeholders, from partners who have worked hand in hand with national governments, from the private sector, from users of assistive technology, from service providers, and how each of them are playing a critical role in informing our strategies and addressing the global needs. In the interest of time, I won't go through the different areas because, as I said, you'll hear directly from many of them. But just to say, we have a huge and really important job ahead of us, and we can achieve our goals if we think big and if we act together. So on behalf of AT-Scale, just really grateful for the opportunity to speak today and to be a part of this, this conversation.
Thank you very, very much, Alison, for giving us an excellent framework of partnership. I was particularly struck by the figure that you gave, that of Africa's need in this area, only 5% is met. And even that 5%, I'm sure, is not completely met. Fred, give us a sense of the public sector, the policy framework.
Good morning, everyone, and thank you so much. I hope you can see those slides on the screen. And like Alison, I also want to thank you so much for being given the opportunity to speak today about how we translate these ambitious global targets to country action. And I also wanted to say, by means of introduction, while a few of my colleagues, I think, would have liked to represent from our working countries, I'm having actually the pleasure to give you a more regional perspective as I'm overseeing CHAI's global work in the area of assistive technology. So I'm going to touch on some of the work that is happening in the region. But first and foremost, I'm just see if everything works. By means of introduction, very briefly, so the Clinton Health Access Initiative, we're a global health organization committed to saving lives and reducing the burden of disease in low and middle income countries, working and strengthening the capabilities of both the government and the private sector in those countries to create and sustain high quality health systems that can sustain without our assistance. That's our mission. We have offices in, or we operate in 35 countries worldwide, in which we've partnered with ministries of health, often for over a decade, to increase access to treatments and diagnostics for HIV/AIDS, malaria, to vaccines and essential medicines, among others. Perhaps some of you may be familiar with CHAI for some of the global pricing agreements that we have achieved. So to give you a few numbers, those are over 140 across a broad range of different products, and more than 125 countries have been beneficiaries of those pricing agreements. And our approach, the approach that we take as we engage in a new area or in a certain area, is a focus on transformational change. And we look at transformational, and I think why this is going to resonate so well is we look at the scale of impact, is the opportunity to have impact large scale, including large regions, large populations, the breadth of impact, what's needed to truly transform an area, and what's the sustainability of the impact. And when we reflect on the challenge that we're looking at here, building on what Alison's just shared and what our chair has also just highlighted, there's a truly tremendous unmet need that we urgently need to be addressing. With regards to our work in assistive technology, so CHAI is a founding partner to ATScale since 2018, joining forces with a number of major development partners. And obviously, Alison already shared in her presentation the goal and the ambition that we jointly set towards 2030. But the next question is then obviously, how do we take that ambition and translate that into results on the ground? And what I would love to share with you today is some of the work that we have been doing in the past years to catalyze action in line with ATScale strategy. And this very simple slide actually captures quite a bit. It captures an approach that we've now taken in partnership with governments in a few countries that are showing success and that it's been increasingly adopted in new geographies. And to briefly talk you through this approach, the first step is leveraging a series of tools that have been developed by the World Health Organization to be able to conduct a comprehensive situational analysis. And there's two tools that I would like to highlight in particular, part of the Assistive Technology Assessment Toolkit, or ATA. So one is a rapid AT assessment, which is a population-based survey, and one is an AT assessment capacity, which is an assessment that evaluates a country's capacity and current state in terms of policy, financing, products, and provision for assistive technology. So really a 360-degree view on the current state. It's really meant, this first step, to be enhancing and creating visibility and awareness with governments, with partners about the current state of provision, and bring all the relevant stakeholders together on the table to be looking at the same data, the same facts, the same evidence. Because that then informs the second step, which is developing action plans that really prioritize the key gaps that need to be addressed. And speaking from experience, reflecting on some of the priority activities that have come up, these might include, we need to improve and strengthen our data or data systems. We need to tackle some critical gaps with regards to policy or regulation, whether it comes to guidelines that could improve the quality of service provision, the quality of products. So that is the second step. The third step is then taking those plans and in a coordinated manner with all the relevant stakeholders involved, work together on a unified strategy to implement those at the country level. So those are, in summary, the approach that we have been taking in the recent years. I wanted to share two quotes. Feel free to read those, but I'm thinking it reflects very nicely the response that stakeholders have given to this approach, which is that the situational analysis, because it really takes a 360-degree view, has been really representative of the situation on the ground, and therefore really robust to develop good action plans. And then a recognition also from, in this case, government partners, how critical it is to be working together with different departments to tackle this issue, that no one department could be doing this in itself. I have one more slide that I want to share with you, which is some of the early achievements and work in progress. And primarily, I want to use this slide to show some of the momentum that has already been built up and is building, continues to build up across the geographies. I've decided here to focus on some of the countries where we have a program that focuses on assistive technology, but to highlight a few recent achievements. For instance, the government in Malawi just launched a national medical rehabilitation policy only a few weeks ago, which is obviously a major milestone towards a better and more comprehensive provision of rehabilitation and assistive technology services in the country. Similar work is currently being finalized in Ethiopia and Kenya. A few countries are focusing very much on data and data systems. And we have also a few countries that inspired by the policy tools also developed by the WHO with regards to priority assistive products lists that have started to adopt those as an instrument, which is similar to the essential medicines list and a guideline for countries to providing certain products and services to their populations. So all to say is that it's really spurring momentum in many countries. There's much more to be done, but I think we are on a trajectory where things are accelerating, and this is a very opportune time to come together here to present and share this work and discuss where we'll be heading in the future. So with this, thank you also so much for having given this opportunity, and handing over to, I think you, Berit, or to our chair.
Thank you very much, Fred. This is a story developing here. Alison gave us an excellent overview of where we are globally and where we are in the region, and the importance of partnership. Fred has given us an eloquent view of the tools that are available for the public sector to be able to establish a framework for policy and action. But the biggest partnership in health and in this area, I believe, should be the public-private partnership. And that's why I'm glad to invite Berit to give us a sense of what the private sector can bring on the table, or indeed, would they be willing partners? Over to you, Berit.
Yeah, thank you, Karma. Can you see my slides since I cannot see them? Can you see them?
It's blank on my side still.
Yeah, the same with me. I'm not sure why, since I just I tried it in our experiential session, and now it's, yeah. It's yeah.
Berit, have you shared your screen?
Sorry?
Have you shared the screen?
Yes, yes, she has, because they say you're viewing Berit's hammer screen, and it is blank.
Yeah.
So what is Berit seeing on her side? What are you seeing on your side, Berit?
Black. It's black. Just
it
black.
Is all blank on your side?
Yeah.
Because Kama, what she shares is what we shall be able to view. So I don't know, maybe the issue is with a machine that side.
Okay, I can again try, and if not, I need to do it without slides. I'm sorry.
Berit, I saw your slide. Yes.
Yeah,
then
now
maybe
we
when the
can.
Now
slide.
you see it?
Yes.
Now you have arrived.
Yeah.
But then now you do not see it.
Right.
Okay, then I do it this way. Okay, then we at least have a solution. I do it this way, okay?
It's gone again.
It's gone, but it should be there now. Is it there?
Now it is there. I can see a sister of mine.
Now it is
Yeah.
okay. I think what is
Okay, thank you.
doing the other.
You can see it now.
Yeah. Now you can do
Yes.
this.
Okay, perfect. Yeah, I thank you so much. And also for the excellent speeches of Alison and Frey, setting the frame. And I will complement a little bit and share some views from the private sector about innovation to access quality care. And I need to, next slide. Okay, and for the ones who do not know Otterbock yet, a brief introduction. Otterbock has started more than 100 years ago as a little workshop in Germany and has in the meantime developed from this little workshop to a global medtech company with 8,000 employees worldwide and almost 60 subsidiaries. And through our business fields, prosthetics, orthotics, and human mobility that comprises manual and electronic wheelchairs, and our new business field, industrial exoskeletons, we help people to maintain or regain their freedom of movement and prevent secondary health conditions. In our more than 240 patient care centers, we offer holistic treatment solutions. Otterbock has been active in Africa for decades, and we have subsidiaries in North, East, and South Africa. And last year we have newly opened our branch in Kenya. And today I want to share with you our views and give insights how Otterbock tries to achieve health outcomes that make a difference to support persons in need to live independent everyday lives, and what from our experience prevents access to quality care in Africa, and how we can support as a private sector partner governments to innovate access to quality care. Alison has already mentioned it, 0.5% of the population needs a prosthesis or orthosis and 1% a wheelchair. And especially in low and middle income countries, trauma from road accidents are often the main cause for amputation, affecting mostly a young population. And Alison also mentioned that an estimated 5 million people live with amputation in Africa. 75% have lower limb amputations. And many persons in need do not have access to services or only access to basic cares, not fulfilling the minimum requirements to support their daily life activities. And what that means, I would like to briefly illustrate and to share with you what is needed to cope with everyday challenges. Here on the picture, you see Agnes feeding her hens. Agnes is married, she has 3 children and is a farmer, and she lost her leg due to a blood clot. And as a consequence, she has no longer been able to fulfill her daily duties, such as feeding the hens and growing corn and selling her farming products at the market and caring for her children and her family, cooking, doing laundry, before she has been fitted with a prosthesis. And you also see Robert. He's in the process. This is Robert. He's in the process of being married, and he's an instructor and trainer in a seminary, business developer and coach, working in a consulting company. And he lost his leg as a child due to a road traffic accident. You also see here Jeremy. He's married and has also 3 children. He's working with DHL supply chain. He's doing farming at his home. He has cows and goats, and he has been amputated due to a snake bite. And Edwin, you see here at the last picture, you see Edwin. He's a family man. He with 2 children. He has a diploma in international business management. And he is really a sportsman. He loves sports. He's a head coach for para table tennis. He is an assistant club coach for para badminton, and he's doing additionally amputee football, and he lost his leg due to cancer. So from what they all have in common, they need to be able to walk on uneven ground. They need to vary the speed, for example, to catch the public transport, and they need to overcome long distances by walking, and they need to carry load. And from the clinical perspective, there are many factors that determine the health outcome and the best rehabilitation. This is beside the technological solution, the collaboration and the rehabilitation team is critical, and to follow standardized treatment pathways, including gait training, quality monitoring, and outcome measuring and follow-up care. In many African countries, mobility aids and assistive technologies have been low prioritized in the past. In some countries, they are even not yet included into national health plans. And resulting professionals are missing in terms of number and competencies, and care infrastructures are rare. Since they are mostly localized in urban regions, persons seeking care need to travel long distances. And since mobility devices are often not part of universal health coverage, persons in need often cannot afford services or even transport to services, exposing them to financial hardship or poverty, either by the cost of the treatment or by excluding them to play a socially and economically active part in society. So many approaches and the perspective on innovation are so far focused on reducing the cost of the product. However, this is only one side of the coin. Certainly, product costs will decrease with increasing volumes and infrastructures. However, innovation is mainly required in terms of service delivery and supply chains. A countrywide patient care infrastructure needs to be set up to ease access to services. And digital technologies can support a wider outreach to persons, to patients. For example, central digital fabrication may play a critical role in increasing treatment capacity and quality, thus making efficient use of the rare personal resources. But also very important custom and import challenges need to be overcome to ensure smooth delivery across borders, further reducing lead times and cost. And therefore, to scale up services and a sustainable ecosystem needs to be built up, as Alison and Frederick also referred to. And Otto Borg proposes a multi-stakeholder partnership between governments, civil societies, funders, and the private sector to build this up. And I think we all would agree that the ownership of the government is very critical for the success. The government needs to lead the strategic plan for scaling up quality services and developing the policy framework for smooth operations. And implementing partners can support with technical assistance and funded with catalytic investments. So the role of the private sector, such as Otto Borg, is to supply assets in support of scale up, such as materials and equipment, provide market access pricing for its assets, train its professionals, and deliver clinical services. And Otto Borg also is able to support in outcome evaluation and scientific research through our worldwide clinical network. And Otto Borg is very much looking forward to working with governments and other stakeholders committed to innovate access to quality of care for mobility and assistive technology and in the future. So therefore, I'm very happy to have these different relevant stakeholders here on board in our panel and to discuss together how we can make this happen. Thank you.
Thank you very much, Berit. And we are rounding things up here. We've had the weight of the problem. You've had the possibilities on the public sector, and Berit has just given us a sense of what's happening in the private sector. David, as a service provider, you need all the above. You meet these things on the ground right in front of your institutions. Give us a sense of
Hello, I think I lost Professor Kama. Am I the only one?
You know, I think we all lost him.
Okay, he's back.
He was frozen, but I think you go ahead. Yeah, I think the message was clear from him.
All right. Okay. Thank you, Berit and Kama. Thank you very much for having me here, everyone, and the other fellow panelists, and for the very faithful attendees that we still have with us, despite we started a bit late. So thanks, everyone. My name is Davide, and I currently work as a CEO of Corsu. Just in a nutshell, Corsu is a rehabilitation hospital located in Uganda, which has been operating for now 12 years. We do provide specialized surgery in the domains of orthopedic and plastic and reconstructive, and then we provide a vast array of medical rehabilitation services, ranging from physiotherapists and, of course, production of prosthetic and orthotics. We do not produce wheelchairs. It's not cost effective, but we do assemble, tailor, and then give them to our patient. In terms of number, we are looking at about 5,000 specialized surgeries per year, of which the majority are orthopedic, and the good number are, in fact, unfortunately, amputation as a result of trauma, as Berit mentioned before in the statistics. But in this part of the world, some of you know very well, we have another disease that sometimes leads to amputation, that's osteomyelitis, which is bringing us to a different set of discussion on how to treat and prevent it. In terms of prosthetic and orthotics, the team, of course, is able to produce about 1,000 to 1,500 items per year. Consider that we are not even 200 staff. And so it's a lot of work. We have a national coverage, and we do also receive patients from South Sudan, which is another area totally underserved. Dr. Kama, when you were referring to the fact that disability is always low in the agenda, sometimes we have also experienced it in countries that are neighboring Uganda. But for reason we understand, I am not here to criticize, we understand why it has not been brought up on the agenda at financial and political level. But it's important to mention, and also from Frederick that has that angle of the region, some of the rehabilitation centers, some of the service provided located in this region, they also serve patients coming from other countries. So that's why the regional perspective and the reasoning at regional level is so key. It's so key. Anyway, just to finish about Corsu, we have also been accredited by ISPO in 2018. All right, our production is both conventional with polypropylene lamination, but we also tend to look into new technologies. Why? Because regardless where the patients come from in terms of social strata, we want to give them all the available opportunity. We want to give them a choice. And I think that's very important from our side as service. The patient deserves to have a choice. Not like 20 years ago, 15 years ago. Many of us have been around for a long time, where the choice was actually very, very limited, and it was a give or take situation. So we want our patient, regardless where they come from, to have a choice. Yeah, and that's very important to us. In terms of the subject that I am meant to discuss is about access, which has to do with affordability as well. Now, most of the patients treated by Corsu, and I'm sure by other friends that are also listening, are vulnerable, and they come from indigent situation and context. They are not able to afford or to pay for the item. That's a fact. That's a reality. So every day we have to deal with this. How do we provide the best quality to a portion of the community, of the population out there that can barely afford the transport to reach the hospital? That's the question we have every day. So I would say that in Uganda, there is a bit of a situation of collaboration with the government. There is a good understanding, although the allocation of finance towards this is not really as we wish. So what could we do? First point, as Dr. Kama, you mentioned it before, the importance of a more dynamic private-public partnership. That's key. We need to know, as it was said before, who is doing what plan, and I don't want to repeat what has been said by the panelists, but to capitalize on a public-private partnership is key, and stop seeing this as a competition. I'm very happy that you kept referring to partnership and working together, you know, both Alison and Frederick, and also you, Berit. That's it. If we keep seeing it as a competition, we are not going anywhere. Why? Because, for example, one thing to improve quality and accessibility is to be more solid and robust in terms of standards. Not only standards for the production, but also standards of what we import. What are the components and the items that we feel that this country should be using for manufacturing quality items? How can we harmonize, even if we are within the private, and Corso is a private not-for-profit, even if we are within the private sector, how can we harmonize the pricing of the items that we manufacture and distribute? We have to move into a more systemic and coordinated situation, both in terms of importing what and for what, but also once we issue the items, what is a reasonable range that we should be looking at? As far as Corso is concerned, we are forced to subsidize massively the production of the items. Without subsidizing it, 70% of my clients will not be able to receive it. How do we subsidize? Through private initiatives. So it's important that also development organizations, if they are manufacturers, they should consider that angle. Some patients can pay, and for those who can pay, we can use the funds to support those who cannot. But of course, donor funds remains very important. So standardized type of components and material that is being imported, being more harmonic in the way we cost and we price the items. And I don't want to repeat the partnership and so on. Here in Uganda, but I know in other countries, there is still a bit of a challenge of import taxation, all right? It's not on top of the agenda, but those are small things that would reduce the cost of production, allowing some of us, like Corso, also to make the products more accessible and affordable. Another important point, and here I will close, training of staff. I am very proud of my team, and I'm pretty sure all of those who are talking, you're proud of your teams. They are very hardworking, but the technology in the area of AT and assistive technology in general, it's ever evolving. Now, if we want to keep diversifying the product, improving and giving options to the patient, we also need to inject more attention to the capacity development of staff. It's not just enough to do a good limb. It's important to be up to the pace with what the technology is out there, because otherwise it will be very difficult to ensure the same quality. And we are falling back to the same situation where we can only offer one or two products. Two, research and academic advancement. Producing devices is not just about the production chain and the cost and how the patient comes here. It's also about understanding. In our experience at Corso, we have realized that through research, joint research with other hospitals and centers, CCBRT, we had a great research. They're based in Tanzania, but I can mention others. They come with grants, they come with technological advancement, they come with training, they come with visibility, they come with experience, which can be injected in the planning, because planning always needs also review. Frederick, would you agree? Which comes into the planning that we mentioned before. And last, to conclude, and forgive me for taking a bit longer, COVID. Production of assistive devices is something that has also been affected, not just because the team are affected, like all of us as individuals, or patients are being affected for obvious reasons. Cost of production have increased. The use of PPE doesn't come free of charge, not in this part of the world. The attention of social distancing, how we deal with the patient in a situation of COVID. And we know that COVID is coming in waves. That also has to be weighed within the discussion. So I hope I've touched a few points, maybe to stimulate the discussion later. There is no silver bullet, so I don't expect to come here with any solution or silver bullet. I just wanted to give some hints. I hope they will be helpful, and thank you very much for listening.
Extremely helpful, David. If you think that those were just a few hints, you've challenged everybody and upset the cat. You have taken the concept of public-private partnership and gave it life, that it is not about public and private, but working together. And this work together is to improve choice for the clients. And that's a point that I want to underline, choice for the client. And that choice must make it more affordable, not less affordable, and can't happen if we don't do research. Research must not only be seen as technical research, but even sociological research, for us to be able to understand the environment that we sit in. And that brings us to the next two speakers, who are very, very special speakers. And I want to challenge them to give their full potential and attention for this. They are two young ladies, young but extremely wise. They are soft-spoken but are tough advocates. So I want to bring that to the table. One is from Nigeria, the other one is from Kenya. You would consider those to be the two epicenters of technological advances in the region. Every fifth African is Nigerian. So every fifth person with disability is Nigerian. And when we are talking about that 5% only coverage, I'm sure that it's even lower in Nigeria. Saba and Fatma, the terrain we live in creates disability. Some of it is because of the conflict and things that are happening around us. Some of it are because of the birth and care problems. And the terrain we live in also make it extremely difficult for people with disability to have choice and to afford the best that can make them realize their full potential. I want you to speak to this Saba, and if you don't mind, use the next 4 minutes extremely well to give us a sense of what you had this morning and what you lived through and any solutions. Saba Akintola.
Good morning, everybody. My name is Akintola Saba. I'm a prosthetic user and I'm also an amputee advocate. So I'm a dental student currently in University of Ibadan College of Medicine, and I also use prosthesis, like I said earlier. So now my journey with mobility assistant devices started about 17 years ago when I had a car accident, which led to the amputation of my left leg. And since then, I've used a variety of mobility assistant devices like crutches, I've used wheelchair, I've used walkers, and eventually I'm currently using a prosthetic leg. So when I started using a prosthetic leg, I started with a very crude prosthesis. It was heavy, it has very little functionality, and it caused me a lot, it gave me a lot of sores and bruises. But that was all my parents could afford at the time because its prostheses are very expensive and they are really very expensive. So after that, I had to change my prosthesis often because I was a growing child. So I have to change it often as soon as I grow taller, I had to change my prosthesis so that it's not going to affect my gait. So that was a factor too, because Nigeria does not have an insurance policy that covers prosthetic use. So all the payments and treatment and rehabilitation had to be out of pocket. So this constituted a huge financial burden on my family. Apart from the fact that prostheses are very expensive, the cost of getting one is also really expensive. I had to travel a long distance, about 300 kilometers, just to get a new prosthesis, because there are very few centers in Nigeria that make quality and affordable quality prosthesis, actually. So as I grow older and my demand for physical activities increases, I had to improve the type of prosthesis I get also. So I had to look for prosthesis that gives me durability to get me through the day. I had to look for a prosthesis that has high functionality, because I'm a medical student. I have a lot of physical activities and I'm also involved in sports. So those factors are the reason why I need to get a high functionality prosthesis. Also, I demand a prosthesis that has a good cosmetic appearance, because this would affect my self-confidence, and I'm going to speak for a larger percentage of amputees right now. The emotional part and the psychological aspect of being an amputee is a lot greater than the physical aspect. So the cosmetic appearance of a prosthesis is really important to majority of amputees. So currently the prosthesis I have gives me the durability I need. It gives me the functionality I need for my day-to-day activities. But the cosmetic aspects of the prosthesis can be worked on. And the current processes I'm using, I had to get it crowdfunded, because it's really expensive. The higher the functionality of processes, the higher the cost of acquiring it. So I had to get public donations in order to get a prosthesis. And I had to travel a long distance. I had to travel out of my country to get the prosthesis I'm using right now. So the financial aspect is a crucial part of getting a prosthesis. The cosmetic aspect is also a crucial part. And the technical know-how of prosthetists is very important, because I've had a very bad experience with a bad prosthesis, because I was given a prosthesis that was made with an inferior material. So I was just crossing the road and the prosthesis broke down in the middle of the road. So it was a really bad experience. And these are the gaps we need to work on. The current model of prosthesis we have and what it could be. The cosmetic appearance of the prosthesis could be worked on to make it a little more skin-like. And a lot of prostheses have a Caucasian skin color, and a large percentage of Black people also use prostheses. And this is not to diss anyone or attack anyone, but it could be better to get a skin tone, a Black skin tone for Black amputees, and a more skin-like, and not just fabric. Because right now, for prostheses outer covering, a fabric is being used to imitate the skin color of the amputee. But it would be a lot more believable if it's something like a silicone outer covering that is being put in place, and that would really help in the social acceptability of amputees. Also, to round up my points, I don't want to take too long in presenting this. Also, cultural and environmental factors affect the availability of prostheses and acquisition of prostheses. In this part of the world, a lot of people tend to give less importance to physical empowerment, and more importance on internal diseases and all that. So more awareness and sensitization could be done to sensitize people and give people an idea of what they could have if they actually try to strive for it. And we could also make life a lot more easier for amputees if we can accept them socially and if we can give them everything they need to thrive. So thank you. If you have any question, I'll be happy to take questions.
Thank you, Saba. I wish I could give you more time to educate us more on this because you've just transformed the discussion. You may not know it, but you've just done that. And I can imagine how much struggle we are going through right now in Africa, trying to bring oxygen and ventilators because of COVID, because the lung can't pull in enough air. But we're not thinking of bringing the same effort to people whose leg can't move, and therefore give equal assistance. You're very, very right that the things that are inside us are given more attention than the things that are outside. Excellent. Fatima Mohammed, you are here because you deserve to be here. Your organization focuses on the northern frontier in Kenya. You'd give us a sense of what you're dealing with there and whether all the things we are talking about can apply there, not on the high streets of Nairobi or Kampala, but on the border with Somalia and Djibouti and South Sudan. Fatma, karibu.
Thank you so much, Professor. My name is Fatma Mohammed. I'm the CEO of this organization called Northern Nomadic Disabled Persons Organization, NONDA. NONDA advocate for the rights, inclusion, and participation of persons with disabilities from nomadic and pastoralist communities. This organization was started as a result of one of its founders who was involved in an accident almost 10 years ago. And this person was not able to participate into society the way he used to participate. He could not achieve his full potential, and that's when he realized that there was a need, and that's how the organization came into being. So the area that we work in, the counties that we target are apart from disability issues being in periphery in Kenya. Now this area is even more marginalized because of the weather, because of how far it is from the town, the infrastructure, and so on. This area is one of the areas that has the harshest environment. Weather is very hot, rocky and sandy terrain, which cannot accommodate even wheelchairs for a long time. But persons with disabilities from this area, most of them use wheelchairs, not because it's their will to use wheelchairs, but because they could not afford the prostheses and other devices that would suit them well, the quality ones, or even the non-quality ones, because the non-quality ones will just increase their it will just increase more of their challenges in terms of expenses, because as already Saba said, these processes which are being produced in our countries are not very quality, and so they cause people to become even more disabled in some cases. So actually, this one event that we organize every year, this event is called the Desert Wheel Race. The Desert Wheel Race is a competition between the wheelchair users. We have tried to see how persons with disabilities can participate in the sport of their choices, but it has been seeming difficult because people cannot get the assistive technologies that suit them well. They cannot, if they are amputees, they are not able to access prostheses. If they are a person who are with other disabilities that they need other technology apart from wheelchairs. They are not able. The wheelchairs cannot be sustained in those environments, and that's why we're not even able to rotate our sports into many counties as we would have wanted because of these challenges. I would say that as our government have put in place very nice policies for persons with disabilities, we have very nice policies that are for persons with disabilities. But unfortunately, I would just say that disability matters has been most of the time on the periphery, and the implementation of these policies has become difficult. And so on, and so because of this, the opportunities that they are there, that the government are failing to see is if persons with disabilities are getting these assistive devices, the right assistive devices for the right environment, then they'll be able to participate very well, and they'll be able to achieve their full potentials. And this means a huge contribution to the economy of our countries. I'm saying huge contribution to the economy of our countries, because persons with disabilities are known to be living a very expensive lifestyle, even though they are among the poorest in the society. But persons with disabilities are the ones who are living a very expensive lifestyle, because if it's a wheelchair user has to go somewhere, then a person has to accompany them most of the time. If it's tourism, I would say just even to the service providers, I would say, can we think about different terrains when we are producing our assistive devices, our mobility assistive devices, so that everybody can participate, cannot feel left out because they cannot get assistive technologies that they suit them. And to the government, can we empower persons with disabilities so that persons with disabilities can participate fully and live dignified lives and contribute to the economy how they're supposed to be? Thank you so much.
Thank you very, very much, Fatima. You know, in my limited English, command of English, the word pastoral and nomadic conjures in my mind distance, walking or running, traveling long distances as part of your life. So imagine if you have a disability, a physical disability, how do you live in those circumstances? You're virtually condemned without any doubt. So we don't have much time. And I just want, we have 22 participants or more right now. Lots of hands are up, but I will not allow them because time isn't there. What I want to do is to give a minute each to each one of you, having heard everything up to the advocates. What do you, 2 or 3 things, do you think we should do differently to really start making a difference to people with disability, not in Nairobi and Kampala or in the Lilongwe, but all the way to where Fatima is working? Because these people deserve better than here. Is our technology there? Is our strategies and policies there? Are the partnerships focused on that area? Or are we still superficially there? David, are the services really there? How do we make it work? Let me start by giving the first minute to Alison. Alison, you've been listening very keenly. What did you hear?
Thank you very much. I heard a reinforcement of us, that it was really important to be thinking about us, and that we all have a role to play, and that there needs to be a movement away from competition, but really focusing on the experiences of different individuals, and to continue to learn, as we did today, about what is most needed. So it was really helpful to hear the priorities. For example, as Saba said, we need to be sure that we're focusing not only on bringing the services closer to individuals, but that we also have the right services. Fatima is also saying in terms of the appropriate, the environment. So we have the environment that we need to be thinking about. We also have the individuals and the cosmetic elements for individuals. We need to be thinking about all of those pieces. And also thinking about what our governments need in order to have as evidence to be able to convince them that they also need to be a part of these solutions. So I think for me, it's continuing to remember that we all have a lot to learn. We can each bring our different elements to this, but it's going to take listening to one another and what's really critical and what each one of us needs to be able to come to the table and solve this together.
Thank you, Alison. Fred, our policies, are they granular enough and segmented enough to cater for various geographical terrains and various physical disabilities?
That's a very big question. And the answer I would say is probably not yet, but I think it's moving in that same direction. I think it's reflecting on the intervention that you made just after the presentation, which is we're on a trajectory, we are on a journey. And I think there's more to be done to make those policies really encompassing the breadth of different needs across the different contexts. I do think, reflecting on this discussion, it also reinforced the importance of building, in doing so, ensuring that the adequate frameworks are in place to ensure quality of products, quality of service provision, and ensuring that those frameworks exist to be allowing to bring that services into different areas or through different populations, perhaps which are not yet fully in scope of some of the existing policies. That's a key reflection, in addition to reinforcing the messages about the partnership and the complementary capabilities, which has just been brought up. So I hope that addresses your question, but I'm sure we can fill an entire discussion about the existing policy and the challenges and opportunities with regards to improving and strengthening policy.
Thank you very much, Fred. Berit, speak for Autobac here and speak for the private sector. Does your research and development have room to focus on northern frontier of Kenya, on the nomadic and pastoral people who probably need more physical movement than some of us who are sitting in front of computers?
Yes, Autoboc, from the technological point, I think everything is there. We do not need new products. And this is what I also mentioned in my speech before. The products are already there and in place. And we are doing technology and manufacturing, providing technology to people and to people everywhere. If there are nomadic or pastoral persons, or if they live in urban settings, or if they live in other settings. So I think this is not a big difference, and we have a wide range of technological solution to support them. I think that the major hurdle up to now is first of all the awareness at the governmental level, and that leads to the fact that this issue is very low prioritized. And I think this is where we need to change perceptions and need to change perceptions that health is an investment and not a cost, and that we look more into the health outcome. And this is, I pick up what Saba said and Fatma said. So sometimes you have an oversupply of low-end devices and that are not functional and do not really serve the people. So we need to change this and making the right investments to really support people in their mobility. And for this, we need data, as Frederick also mentioned in his speech. And this is what we need to do different. And also what my previous speakers already highlighted is we need to look more at the framework and what is really needed in terms of an enabling environment, and that the right technologies really comes to the point of care. And so we need infrastructural innovation. And the third point, what I would like to stress, then we can look at the technology. What is the right technology under the given framework? And then we can, from existing technology and also emerging technology, choose the right technology to support this. But I think this is the third step. So first of all, the awareness, then the framework, and then the technology. And this is where private sector can support.
Thank you very much. David, I congratulate you for what you're doing, extremely important. I believe from what you have told us, you are a provider activist. So I want to take you with me to a scenario where, as Saba told us, she is on the busy streets of Lagos or Ibadan, and her leg gives up on her. Nigerian drivers are good friends of mine, but they don't know how to stop quickly. Or, as she said, the cosmetic side, that this beautiful African woman, for her to move and go to school, she must have a Caucasian leg or a Caucasian. Where are we failing? Where is the gap from the service delivery standpoint?
Right. Thank you for framing the question in such a touchy way. And the story that we have had this morning these are stories that we hear every day. I mean, many of us. So it's something that goes right in there each and every day, and we need to dwell with it and find solutions together. So I will not repeat what has been said before. Now, from my perspective, a couple of points. The first one, it's really, I insist, standards. It's not just enough to do things, not anymore. So I think a joint effort, and this links to the third point, I think, of Berit in terms of technology. It's not enough to produce a limb because somebody, for some reason, went through an amputation. That's not enough. So we have to be stronger, all of us collectively, in defining and implementing standards, which, as we said before, is not just about production, but is also in terms of what we get for producing, so importing. The markets have gone wild. And many of our patients are going to the cheapest center. They go for the cheapest solution, which is not always the most functional. So to me, standards are important. We need to increase the curiosity from health insurance providers. The packages and the premiums that are given under health insurance for provision of prosthetic and orthotics are ridiculous. Ridiculous. Many of the countries where we work don't have social funds. So it's not just about the government, it's not just about the service provider or the private sector for that matter. The awareness, which was, I think, the first point from Berit, but others, should spread across different entities, even the corporate world. Actually, I really believe that with stronger health insurance systems and packages, some of the challenges addressed that we have could be addressed, could be looked into. Now, in terms of the cosmetic, aspect of the limb that you were referring, look, that's how I open also my intervention, and I think we are all on the same page here. patients have the right to choose what's best for them, all right? So the financial aspect can be tackled in different ways, and I don't have a solution for all. Actually, I don't even have the solution for Corsu. We are dwelling with it every day. And the technical aspect should be addressed to clear standards, which embrace different technology at different levels so that the patients can actually have a say to that. One thing before I conclude, the way we are working in Uganda as Corsu is that we have learned, all of us, we cannot work in isolation. So currently we have partnership with over 50 local organizations distributed in the territory that help us to identify the clients and refer, but also to follow up. Because some of the patients that we have, like from those mentioned by the organization Nondo in North Kenya, which I met many years ago, once we provide the limb or the wheelchair, then the patient disappears. They go back. We have no way whatsoever to liaise with them. So have this chain of communication, formal or informal, with the patients to get feedback is absolutely important. Once again, let's not just produce the limb, give the limb, and goodbye. No, we need a feedback from the patient. So partnership at higher level, but for service providers, of course, as a service provider, it's very important that partnerships are also with organizations on the ground that can help us always, listening and understanding from the users. Because sometimes the service provider is not necessarily in touch with them. And that was my last point. So networking at local level can also help a lot this feedback mechanism.